So Dr. Leff, what was your experience of the AIDS crisis like?
Well, I started in private practice here in 1985, having been the interim county health officer for not quite a year. And actually, while I was the health officer, the first HIV death happened in Santa Cruz. And one individual came up to me, knew I was going to private practice, asked me if I would take care of him. He had HIV. In those days, that's about all we knew. We knew it was a sexually transmitted infection, and we knew it was deadly. And we were just able to do a blood test to know whether or not an individual had HIV or not. I went into private practice and wound up seeing many HIV patients. And during the course of 20 years, saw basically the epidemic from the beginning, when we had absolutely no treatment at all, to the days now when treatment is quite good. In those early days, the things that were the most terrifying were, one, how do I catch it? What if I'm close to this person? Do I get HIV? If I needed to refer somebody to a surgeon, they were very nervous in doing anything with HIV patients. So it got to be pretty lonely in a way, because the rest of the medical profession was scared, very scared, for good reason. Deadly disease, a virus that we didn't quite know how it was transmitted. And just think about the nursing staff at Dominican Hospital who had to take care of my patients. With the big problem in the early days being what we called opportunistic infections, since the AIDS virus decreased people's immunity, they developed these very, at the time, weird infections that most physicians had never seen before. Or if they had seen, it was maybe in medical school at an academic center. But the bottom line is, even if you had some knowledge about how to treat one of these opportunistic infections, they were different in this disease population. They were not the same. And so the frustration and fear about what to do, how do you treat pneumocystis pneumonia, which is a fungal disease that affects the lungs. And the only time that disease was ever seen before was in cancer patients who had their immune system destroyed. And it was still rare. The only way you could even get one of the medications to treat it was through the NIH in Washington. It was not available otherwise. We finally figured it out. We finally could use a standard antibiotic to deal with it, but it took a while to do that. In the early days, lots of young people were dying. A little later on, there were lots of older people dying because they got blood transfusions at some point during their illness. But initially, it was mainly young gay men. And so when, as a physician, this starts getting a little hard. As a physician caring for 18-year-olds, 20-year-olds, or slightly older who are dying, no matter what you do, is very difficult. In fact, there were so many deaths in those days that Santa Cruz Hospice eventually asked me to be their first paid medical director. Mainly because, other than the oncologists, I was referring more people to hospice than almost any other physician in town. There was a doc in Watsonville who was taking care of patients in that area, but in Santa Cruz, for the most part, I was the main person. Well, think about this, because for me to leave town with nobody to back me up to take care of those patients became a burden. You know, I didn't leave town very much. And the fact that 7 o'clock in the morning, 7 days a week, Dominican hospital rounds to take care of anybody that was there. Noon, going back and crossing your fingers that they were getting better rather than worse. And there was a lot of drama in a way. I remember one prominent man who was dying at Dominican, and the word got put out that he was, and the lines in the hallways to say goodbye were 100 feet long at least. Long lines just to say goodbye to somebody who was dying.
What was he dying of?
Hmm?
What was he dying of?
I don't remember which well, I think I do. He had pneumocystis. And in fact, that one individual, it was to just show you how difficult things were, had some lesions in his eyes. We could see them. Didn't have any idea what they were. And one of the ophthalmologists who I used, and all these specialists had to learn about HIV disease. They didn't know about it. So when I went and said to the ophthalmologist, I need your help taking care of AIDS patients, he would go, oh my God, he'd have to learn all the things related to the eye that HIV caused. Well, he looked in the eye of this one patient. He had no idea what it was either, which always gives one some confidence. Anyway, sarcastically. At any rate, the next day or a couple of days later, the ophthalmologist came back to me and he said, I now know what it was. The first reported case of pneumocystis, of fungal infection in the eye, happened to be reported in his journal. And so this patient wound up dying of basically systemic pneumocystis, which we always had trouble treating. Not always, but mainly.
Why did they call you the AIDS doctor?
I think mainly because I probably saw 90% of the AIDS patients in the Santa Cruz area. And in fact, I had a few that came from even further. There was one tremendous help, and that was the folks in San Francisco. So the folks in San Francisco, the docs, one an oncologist, one an infectious disease doc, They were the people that first reported Kaposi sarcoma, which was the skin cancer that AIDS patients got, and they were the first to report it. And San Francisco, as I think most people are aware, became a center for the, quote, treatment of HIV infection. And fortunately, these guys were great. I can call them up anytime. Hey, what are you doing to treat this thing today? And they said, well, we're trying this or we're trying that. But that let me stay at the state of the art, which unfortunately wasn't very good, but it was as good as it could be. Yeah, there wasn't. And so in many ways, I became a very knowledgeable specialist in taking care of AIDS and the opportunistic infections that occurred. But it's hard to imagine because I'm basically a generalist physician. I mean, I was board certified in a few things, but I was not an infectious disease specialist, at least not when I started. And the kinds of opportunistic infections these people were getting required a huge amount of expertise and a lot of hope and intuition. So that's basically how I got to be the AIDS doctor and what the early days, AIDS days were like. I mean, training nurses how to take care of HIV disease. What do you do when the pregnant nurse comes to you and says, what is my risk? Now, after a while, we knew what the risks were, but in those early days, you have to really thank the courage of the nursing staff at Dominican Hospital who just did it. They took care of these patients, and I'm sure, I don't know for sure, but I suspect some of the nurses that sort of picked nurses who were willing to take care of these patients, and they were the ones that developed expertise just alongside me. And so the early days were quite traumatic, not only because a lot of people were dying, virtually mainly gay men, but the amount of effort one had to use to train everybody, to try to make sure that as much as you could, that they weren't going to wind up in trouble, which you just never knew. And you know, I did an AIDS, once the AIDS test, the HIV antibody test came available, which was, I think in 1985, in the very, very early days, but took a couple of years. I would test every, 6 months or so just to know whether I was safe or not. Luckily, I was. I'm not sure how I got away with it, but luckily I was. And as far as I know, no nursing staff at Dominican Hospital was ever infected as a result of their care, which in retrospect, they shouldn't have been. It was relatively safe to care for those patients, but we didn't know. We didn't know. And so the first AIDS treatment directly at the virus was an anti-cancer drug that never quite got used for that purpose, and its initials were AZT. So here I am in 1985 initially in practice. It wasn't until about 1989, 3 or 4 years later, and many deaths later, unfortunately. A lot of disability later, during that period. So it was 1989 and AZT came available, and it was a miracle. A miracle. My God. All weight that people had lost, and sometimes it was many, many pounds, started to come back. They started feeling better. It was a miracle for 6 months. And after 6 months, they started losing weight again. The opportunistic infections came back, and it was clear that the AZT was no longer working. So we had this great rise of hope and huge downfall. I recognized right away what was going on, that the virus appeared to be becoming resistant to the new drug AZT, which wasn't easy to take. It caused a severe anemia. We had to give people blood transfusions to keep them on the medicine. But nevertheless, it did work for 6 months, and then it stopped working. Resistant virus. Well, how do you deal with a resistant virus? It wasn't, I don't know how to put it, but most of the physicians who were caring for HIV at the time knew it was resistant to the AZT, but didn't quite or weren't able to come to grips with how to deal with resistance. And I sort of backed myself up. When I went to medical school, which was, I don't know, 20 years prior, those were days when part of the rotation in medical school was to go to the TB ward, tuberculosis ward, which doesn't happen very much anymore. But the thing about tuberculosis is that you need 3 drugs to treat tuberculosis. Because if you used only 1 drug, the bug became resistant to that one medicine. So you learned if you used 3 drugs, it was hard for the bug to become resistant to all 3 at the same time. And so I used that model, although I only had 1 drug. But after a few years, there were 3 drugs. Now, most of the HIV docs were still using 1 drug. If the AZT didn't work, they'd put them on the 2nd drug. That didn't work, they'd put them on the next one or next one that arrived. And there was a lot of research. And the research actually was very, very good, and it was mainly the pharmaceutical companies that were doing the research. And I would pal up with the farm companies, which some people criticized at the time, to be honest. But I felt that if I was in with them, I would know what they were doing and know it before it came out, which was true. It also meant that I got the drugs earlier than people that didn't pal around with these folks. So at any rate, I was also educating the community and physicians about HIV. Eventually, I had patients on 3 drugs on a regular basis. My HIV colleagues in San Francisco, one of which accused me of genocide. These drugs were not easy to take, and there was concern that 3 drugs were hurting people rather than helping people. There was concern that I might be killing gay men by doing this, therefore genocide, right? Well, it wasn't easy to take that kind of criticism, but nevertheless, I pursued ahead. That's sort of my way of doing things, and it was 1996. So now another 5 or 6 years, when a class of drugs came available that were relatively easier to take. And all of a sudden, some studies were being done about using 3 drugs at the same time. And so from 1996 on, 3 drugs were the answer. And we had them. The pharmaceutical companies, you have to, as much as people criticize them, you have to give them credit. They virtually, in 10 years, from when they started in about 1985 to basically 1995, 96, went from a disease that they didn't know anything about to basically developing the pharmaceutical capability to manage it. And it was really, really an event that saved lots and lots of people.
So Dr. Leff, why do you think you got so many AIDS patients?
Well, I'd been an ally to the gay community from very early days when I participated in setting up a gay men's health clinic in Cincinnati, where I was living at the time, and had taken care of a lot of gay men in Air Force when I was stationed in Southeast Asia. So when the AIDS epidemic came into being, it was pretty natural for me to continue to do whatever I could for the gay community. And they knew it, and I respected the patients that I was taking care of. And there was a lot of stigma around just being gay in those days, and stigma now, or at that time, with AIDS. And so it was difficult for them, and not in my way, very difficult for me. And so it worked out. I connected very well with the people who needed those connections. I mean, think about it. People would never touch them because they had AIDS, so you never got touched, except when they came to the doctor. And in fact, when I would teach, I would teach other doctors the importance of touching their patient. It didn't matter whether they needed to or not, they just should do. And I learned that to some extent because of AIDS patients. The people didn't touch them, but I did. And so we made a very intimate connection between me and the patients that I was taking care of, and patients knew that. I also always left time in the day to take care of emergencies that needed to be seen that day. And it was my style of practice, I think, that allowed for people to feel comfortable coming to see me.
Can you tell me about your first HIV patient?
Now, my first patient, Ray Martinez, who would be okay with me talking about him, actually came to me before I went into private practice. They, into my office and said, I have HIV and I'm going to need a doctor. I hear you're going to go into practice. I want to be a patient. And basically, he was my first patient, even in some ways before I started taking care of patients. And I knew his partner very well, and in fact, his former partner I know to this day, and we talk every once in a while. But that was the beginning for me.
You talked a lot about how you were working 7 days a week. So many people were dying. It was really, really hard and painful. What motivated you to keep doing this work, to be one of the only doctors?
I don't know how to answer that question. It's just who I am, I guess. I also took care of a lot of geriatric patients at the same time, so I was motivated to being a good doctor. Some of it's a little fear of being a bad doctor. I didn't want to be a bad doctor. I didn't want to be one of those doctors who people criticized for not giving them enough time, not taking care. So there was some of that. I didn't want to be a bad doctor, so I guess I have to be a good one. And that's basically what motivated me to keep going. I did have a couple of docs who would take call from me every once in a while, so I did get some rest. And later on in the practice, it was more routine for me to be able to take some time off every once in a while. But during the practice, we did some outrageous things, which when I look back on it, it's sort of interesting. One is using cannabis for helping people gain weight. In those days, we weren't even allowed to suggest it. And in fact, the Drug Policy Alliance eventually got the issue to the US Supreme Court on whether doctors had the right to recommend cannabis to patients. In the meantime, I'm writing prescriptions. And I'm saying, always hold this prescription in your wallet, prescription for cannabis. And Valerie Corral, who was a prominent person in the cannabis area at the time, she dragged me to the chief of police and sheriff to talk about the fact that I'm giving out prescriptions for an illegal substance. But it worked out because the police in Santa Cruz, when they came across a prescription for me, left folks alone. Even if they were plants, they left them alone. Now you have to remember, this is a Schedule I heroin-like drug that Arnie Leff is prescribing to people. Any rate, I got away with it. And there were also the issues of helping people that die and what some physicians did in order to do that, which again was difficult and somewhat illegal. Well, if you asked, and in fact there was a survey of physicians taking care of AIDS patients in San Francisco and asking them how many participated in euthanasia, and the vast majority had. So when you think about that issue, it becomes even more difficult to deal with some of the problems that AIDS patients were having. But all that said, there was a lot of community support for me. Even though the medical profession was scared, the nurses we had to train, there was the Santa Cruz AIDS Project, which really helped support our patients. Without the Santa Cruz AIDS Project, it would have been hugely difficult for me to take care of many of those patients, because the Santa Cruz AIDS Project had people that came with those patients, that transported those patients, that helped with food, and on and on and on. I can go about that, but now some very prominent people in those days who were in charge. When you think about John Laird, Senator Laird, who was the executive director of the Santa Cruz AIDS Project in those days. You know, mayor of the city of Santa Cruz. It was hugely important to have that kind of support. And to be honest, you know, you asked what motivated me. I probably would not have been able to do it without those folks.
How do you think that this experience, going through all of that, those decades of work, how do you think that changed you personally and professionally?
It's called PTSD. I have no question. I have some of that related to my military experience, and I am a 100% disabled veteran to some extent as a result. It's not severe, luckily. And in some ways, my work helped to deal with it. Just taking care of people helps with that problem somewhat. But when I look back on the many, many people who died, when I look back at even some of my outbursts, which would happen every once in a while, it was clear that I was under a huge amount of stress. And it was not only stress from the practice, but financial stress. I mean, I can't tell you how many patients I had who were not able to pay me at all. And in fact, I tell people the story. One of my patients happened to be my accountant. And one day he walked in, I was having trouble making payroll. And part of the problem is when you have a practice taking care of very difficult patients, it costs a lot. You need more people to do it. And he walked in one day, wrote a check for 10 grand and said, pay me whenever you can. But so the financial stress was unfortunately in addition to the practice stress. And that was hard to handle all of it. Luckily, I could refinance my property, which is small, but in those days, it was coming up 10% a year for the most part, and I could refinance, and that sort of saved my my financial life and allowed me to keep going. Eventually, I moved my office because it was too expensive. I was in front of Dominican Hospital, but later on moved to Frederick Street to save a few bucks. But so there was a lot of stress in my life during that, especially the early periods. And a lot of the stress, unfortunately, was unnecessary. And my patients would hear me on a regular basis yelling in the telephone to some insurance clerk who was reading a computer, knew nothing about anything, and basically telling me I couldn't hospitalize this patient because the computer said they didn't need to be in the hospital. But the computer didn't know anything about AIDS, nothing. So a lot of yelling and screaming and nervousness. I did have one patient whose blood counts went so low, white blood cell counts, that I was really fearful he was soon not going to make it. And he became somewhat of a friend of mine. A lot of these folks, I mean, part of the difficulty is I was seeing these people sometimes every week, and many of them became very close to me and me close to them. And he was one of those folks, and I found out that there's an experimental drug made by the Shearing Corporation, which was the pharmaceutical corporation, to reverse his white blood cell count. And I called the scientists who were working on the project. They refused to give it to me. I begged them. I begged and begged, and then threatened and threatened. And they still wouldn't do it. And he wasn't going to make it. And almost around the same time, the Shearing pharmaceutical representative walked in my office. And I basically laid into her, basically saying that I will make sure that the Shearing representatives can't see any doctors in Santa Cruz ever again. That I was sure I could pull together a parade downtown with anti-Shearing signs. I mean, literally, I'm livid that I can't get a hold of this medicine that was going to save the life, or at least for a little while, of this individual who I'd become quite close to. And the Shearing representative looked at me and said, "Take it easy. Just give me a few minutes." She walked into my office, made one telephone call, had the drug the next day. And what I learned, and I learned a lot over those 20 years, one of the things I learned was that the scientists don't run the pharmaceutical companies, the marketing people do. And once I got to the marketing person and told her what I needed, it just took one phone call. And from there on in, I knew how to deal with the pharmaceutical companies. And he lived some time longer. In an interesting sort of side of that was one day he came to me and he was clearly not doing well and said, "I want to go to Hawaii for a week." He's on IV therapy. He used to walk around Capitola with a backpack that contained an IV with IV coming into a pump that went into him. And that's how he lived for the remainder of his life, with basically an IV going all the time. which, by the way, we also learned we could do. That was never allowed in the medical arena prior to AIDS. We were given blood transfusions at home. We had no compunction about somebody running around with IVs in with a backpack, and mainly because we knew they were going to die. It was just a question of how long we can keep them going. So he wanted to go to Hawaii, and he went to Hawaii. I called a Hawaii doc and told them I was sending, that patient was going and might need some care. And he, boy, I could, if the TSA existed in those days, he had a suitcase full of IV fluids when he went to Hawaii. He made it, he came back and did okay. But we did everything we could to provide for the comfort and to meet the needs of the patients in those days.
It must have been very painful for you to grow close to so many people and then to have to watch them die.
It was very painful. And I stopped going to funerals. There were just too many funerals. The funerals too hard for me. They were just too hard. And people knew that. And the funerals, many of them were very large and a lot of people were there, but not me. I just couldn't do it. It was the one thing that was just too much.
How do you think Santa Cruz would be different if you hadn't lost all those patients, they hadn't died of AIDS?
Wow. It's hard to know. There were a lot of people who died who were very prominent in the community. I think, it's hard to know. Everybody put their stamp on HIV. Lots of people put their stamp on the community in many ways, who are no longer with us. I might also mention, and maybe lead into one of your next questions, but I had a patient who came to me one day and said his cat had leukemia and he needed a bunch of syringes to treat the cat with leukemia. And so every month or so he'd come and I'd give him a couple of boxes of syringes for his cat who supposedly had leukemia. I don't even know that he really had a cat, but it was at least the beginning of the syringe, quote, syringe exchange program, since by that time we knew how it was transmitted, we knew clean syringes were important and blah, 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 blah. But nevertheless, that was another one of those things that happened out of my practice that I'm pleased about and had no idea at the time, believe it or not. It didn't even occur to me. I was busy. You need syringes, take them. When I was the Commissioner of Health in Cincinnati, the state legislature was discussing a law to make possession of syringes illegal. Up until that time in Ohio, if you had a syringe, it was not illegal. And this was a long time ago. And I basically told the legislature they should not pass the law, that in fact, if they passed a law, they were bound to see more hepatitis, which we knew about, and maybe more other infectious diseases as a result of syringes being illegal. They, of course, did not listen to me, and, well, the rest is history.
What prevention methods for HIV or AIDS would you like to share with people?
Well, there's a number of things. I mean, there is the community prevention issues, which relate to not sharing needles if people are using needles to take medication. And of course, that means how do you get clean needles to people who can't afford it, for example. We did get some legislation passed so that it's not illegal to have a syringe anymore in California, but it's still a problem for large populations, often unhoused populations, who are using syringes and the need to make sure that they're clean. And fortunately, both the county and a nonprofit organization in town are providing clean syringes to folks who need them. So that, on a community level, is a major way of preventing HIV. On an individual level, the need for people to prevent viral transmission through sexual activity, meaning using condoms. I gave a HIV lecture in the early days at UC Santa Cruz and brought with me a box of condoms. The professor didn't like that very much, but nevertheless, at the end of my lecture, I took out the box, put it out, and said, "They're all yours, come and get them." But nevertheless, condoms are important for people who are engaged in multiple partners, especially. Individual prevention, of course, means making sure the blood supply is clean, making sure, in fact, that bodily fluids in those who happen to have infection or at risk of infection are not communicated with to other people. Since HIV is a virus, and it's a virus that's in body fluids. So it's in all body fluids. Once it permeates the body, it's in blood, it's in tissue, it's in tears, it's in breast milk, which creates another problem. But nevertheless, AIDS transmission is basically prevented by body fluids not being contacted, and infectious body fluids not contacting somebody who is vulnerable and not infected.
What would you say to someone who argues that a needle exchange program promotes drug use or causes littering or any of that?
Well, it does cause littering. It does. The answer to that is to make sure that you have people who can clean the streets, and we do have that now. It took a while to get to it. But unfortunately, if you're injecting some substances, such as heroin, it's very difficult once you inject it to pay attention to what happens to the syringe. So a lot of syringe litter is a problem, and in many ways, it's the biggest problem. As far as the issue of encouraging people by giving them syringes, that's been poo-pooed. It's false. It doesn't happen. It's not an issue. Hard to tell people that who have their minds made up, but the evidence is quite clear that it's not an issue. And even the issue of syringe waste is overstated. especially with regard to whether if you give out syringes, that increases the litter. It doesn't necessarily. There's some evidence that syringe exchange programs decrease litter rather than increase it by virtue of the fact that most syringe exchange programs actually exchange some syringes, so they do get some dirty syringes. And the evidence is the syringe exchange programs are really not a problem and need to continue to be supported, not only for HIV, the virus HIV, but the virus hepatitis C, the virus hepatitis B, the virus even hepatitis A, although that's not commonly bloodborne, does happen. And we had an epidemic here 10 years ago in hepatitis A. Syringe programs are critically important. Then also, my experience with syringe exchange programs is that the good ones are also doing their best to try to get people into treatment. They're doing their best to sort of social support of the people that they're giving syringes to or exchanging syringes with, so that syringe exchange programs really become a door to treatment, which is critically important. A lot of people think that folks who use drugs, often bad, not very good drugs, that somehow they're all going to die and we don't have to worry about these folks, and so why pay attention to them? But the fact is that most people who use intravenous drugs wind up stopping using intravenous drugs at some point in their lives. Usually by the time they're in their 30s and 40s, they stop. And so, assuming they made it that long, it's important to recognize that they eventually become, quote, tax-paying model citizens in our community, and just because they used to use drugs, they shouldn't be stigmatized. And in fact, if they're currently using drugs, they shouldn't be stigmatized. They may wind up being important citizens in our community.
What is HIV?
Well, traditionally it's called the human immunodeficiency virus, HIV. And it's basically a virus that is very tricky. It's a tricky virus. It has the ability to be resistant against a lot of drugs. It can change its genetic makeup very easily. So it's a tricky virus. And it is, again, relatively easily transmitted sexually and in really almost any body fluid. Saliva, not so much. But it does seem to coalesce often in sexual fluids. So it is easily transmissible sexually if people are not treated. It took a while to get to the point where we learned that if you're treated and the virus is suppressed, then you don't have to worry about transmission. And there are ways now, medications that one can take if one wants to actually prevent the virus from happening. So we've really come a long way, but it's also been 25 plus years now. And we've basically been able to manage this virus. We can cure it, but only through extraordinary methods which basically means changing the genetic makeup of an individual to be able to keep the virus at bay. And that only happens usually during people who happen to have HIV and some cancers, where they're able to replace the blood of those patients and cure HIV. It's happened in only half a dozen folks. But we can manage it. And although we're managing it, patients with HIV have a higher risk of secondary cancers, have a higher risk of cardiovascular disease. It's still a stress on their body, basically.
Well, thank you, Dr. Leff. Is there anything else that you want to add?
No, thank you very much. I appreciate that you're doing this work, and hopefully it'll have a very positive impact.